I'm here to talk to you about a topic that I'm passionate about, which is that of blood management. I've been involved in blood management since about 1997, where it really wasn't a discipline as we know it today. So anyway, what I want to do is walk you through some of the drivers for the development of blood management programs, and then kind of give you an overview of the strategic plan that we have in place to develop our blood management program. First of all, I thought I'd start off with giving you an overview of where I come from. This is Pennsylvania, which I learned in preparation for this presentation is about 60% the size of the state of Washington, though we have about 2.5 times the population in Pennsylvania that you do in the state of Washington. This is the city of Pittsburgh, which is kind of an islet straddled by the Monongahela River and the Allegheny River that come together at the point, which is where George Washington put the first Fort Pitt into place. It was at the point of the two rivers where they come together right here. Our football stadium is the most important thing in Pittsburgh, and that's located right here. This is our health system. Each of these stars represents hospitals that are part of the University of Pittsburgh Medical Center. We are no longer the University of Pittsburgh Medical Center, we're just UPMC. I guess that's the same way the Joint Commission has changed their name from JCO to just plain old Joint Commission. Anyway, we have 20 hospitals in western Pennsylvania, as is indicated here, with 5 of our primary teaching hospitals located in the city of Pittsburgh. In addition, we have 4 hospitals overseas, 1 in Ireland, 1 in Italy, and then 2 in Cyprus, though I've been told it might be more than 2, depending upon how you measure a hospital. So we're a $10 billion a year healthcare enterprise. We have about 6,000 physicians working in our facility, and we use around 220,000 units of blood products annually. Just to give you some sense of the size and scope of UPMC within the city of Pittsburgh, this is a skylight or a highlight of the city, with right here is the corporate headquarters of the University of Pittsburgh. As you can see, it's the tallest building that goes along with our ego. This used to be the U.S. Steel Tower. There's no longer any steel manufacturing in Pittsburgh. It's all healthcare and biotech. So this is what's happened to our blood spend over the last 6 years, as we've had kind of a generally incremental increase in the costs, where we're currently spending around $53 million in blood products and blood services, which starts to catch the attention of most administrators when you get into those kinds of figures. This is some of the costs associated with providing blood products for the United States between 2004 and 2006, and you can see from here that there's been sizable increases in blood product use in the United States. This is some data from the Healthcare Cost and Utilization Project. If you look at this carefully, what you see here, this is the number of, or rather this is a listing of the most frequently performed medical procedures in a hospital. And what you see here is that blood transfusion is the #1 most performed medical therapy for a hospitalized patient, with a growth rate of 140% over the last decade. So again, these kinds of numbers start to pick up people's attention. The concept of bloodless medicine was kind of at the heart of the development of patient blood management. Back in 1997, that was pretty much what it was, is bloodless medicine. But the bloodless label was fairly negative, or negatively viewed by most clinicians, in that it had the religious connotation associated with it. So the the mileage that we got from using this particular term was not large. So at one point we decided to rebrand, which I've learned from my patient blood management experiences that branding is really important. So we started calling it blood conservation, but got a lot of pushback because there was a thought process that we shouldn't be conserving blood products in the same way we do gasoline. So this term disappeared also, and then we ended up with this term blood management, which was better accepted, except the transfusion medicine world, they said, we do blood management every day. We manage our inventory routinely. And so we thought, well, we probably need to differentiate between what we do in the clinical world from what the laboratory does. And so arose the term patient blood management. And SABM has kind of defined this particular pursuit in this way, is that it's the timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. And I think that the patient outcome is really what we need to keep focused upon. So this concept of patient blood management has received a lot of attention from a number of regulatory bodies. This is a letter written by the chair of the Advisory Committee on Blood Safety and Availability to the Secretary for Health within the U.S. Department of Health and Human Services, basically stating that we need to have a blood management program on a national basis. And this is something that I was involved in. The Joint Commission back in 2007 approached me about leading a group to develop performance measures, which at the time I had no clue as to what a performance measure was, nor did I have any idea of what a standard was. But there was a group of us that spent a lot of time basically taking 89 recommendations for performance measures and boiling them down to 7. And you can find these performance measures in the Joint Commission Measures Library. More recently, the Joint Commission, in conjunction with the AMA's Physician Consortium for Performance Improvement, held a summit to talk about the 5 what are considered the greatest overused medical therapies today, with one of those areas being blood transfusion. This is a car that was parked in the parking lot of my hospital, and so I can see that patients are coming to us demanding patient blood management also. So I built a program at the Cleveland Clinic before moving or migrating to the University of Pittsburgh, and I struggled with trying to figure out, how you go about changing a paradigm. And change is oftentimes very threatening to many people. And this particular individual, John Cotter, who teaches at the Harvard School of Business, has written several books on how you change. And he's created this change model, which outlines basically steps that you have to take in order to get a paradigm change, with the first being to create a sense of urgency. And I think that based on the regulatory bodies getting involved in patient blood management, I think that the urgency is probably there, as well as the cost drivers and the sense that perhaps patients' outcomes perhaps might be a little better if we can avoid transfusions. The second concept is forming a powerful coalition. And this was something that I failed at doing when I was at the Cleveland Clinic. So it was when I arrived at the University of Pittsburgh, it was something that was very focused, as I needed to go from the top down rather than from trying to work from a grassroots position to change how we did things. So what we've done is we've created a committee that we call our Patient Blood Management Committee that is empowered with the most probably powerful individuals within our health system, our Chief Medical Officer, our Chief Information Officer, our chief nursing officers and chief quality officers, so that when they say something is going to happen, nobody can challenge them. And I think that's something that's critical anytime you try to change widespread systems. And then this patient blood management committee, what it does is it basically farms out the consensus of the committee to our local transfusion committees, to the 20 hospitals in Western Pennsylvania, and basically tells them that they're the ones that are going to have to drive it within their local hospital. So the third step in Cotter's change model is to create a vision for change, and that's where our strategic plan comes in place. And this is what I call our 6-point strategy, or our 6-step program to wean ourselves from our dependency on allogeneic blood. With the first point in our strategy to be getting our clinicians to use blood in accordance with evidence-based guidelines, which has not been easy. And these are the evidence-based guidelines that we advocate within our program, within our system. And I don't think these are revolutionary probably to any of you, but to most clinicians they are. And initially, we tried to roll out an educational program through a number of modalities, like brochures, as is shown here. I want to point out UPMC has gone through this branding. We used to have blue and gold as our health system colors. Now we're kind of this pinkish, reddish shade here in gray to distinguish us from institutions like the University of Washington that has blue in their logo also. Apparently blue is the most common logo color. Anyway, we saw from our educational efforts a fairly significant drop. And one of the measures that we developed for assessing the effectiveness of our program was the number of PAC cells transfused per med-surg admission. Because the PAC cells may vary dependent upon the hospital admission, so you need something that's going to be adjusted based on the busyness of your hospital system. So this was the metric that we chose. And we saw, this fairly sizable reduction, which actually translated into, at least based on our administration for our blood bank, a sizable reduction in cost in addition. So we went from 1.25 units of blood transfused per admission to 0.9, and he put a total cost of the savings as $2 million per year. I'm not sure at the time that it translated into the numbers of blood products that we actually purchased from our blood providers. So there's some fast mathematics that may be going on here. Anyway, we used a system called MARS to report what was being used within our system. And each one of these, you can see here, this is a patient right here. What you see here is you have lots of patients being over-transfused. Here's a patient that has a hemoglobin of 10.9 as their most recent hemoglobin value, with a red cell unit being given. Here's some plasma given in 2-unit doses for an INR of 1.7. You can see it was really effective, and the INR is now 1.4. So what we estimated is that about 40% of our blood products were being misused or over-transfused, which goes along with that summit between the Joint Commission and the AMA, and is also consistent with some of the publications in the literature. And this is a series of audits that the National Health System in Britain has done, and the inappropriate use, as is shown here, ranges from around 15% to 48% in British hospitals, and I don't think our hospitals are too much different. Which, when you're spending $53 million on blood products, I mean, there's a sizable opportunity here for cost reductions. Around 5 years ago, we introduced a Cerner electronic health record, which is kind of a total disaster from a clinical perspective in trying to use these systems. But we have tried to leverage the Cerner system to make it more difficult for our clinicians to use blood outside of normal indications. And so what you see here is a page from Cerner showing you the order for a unit of red cells. And the clinician, when they go to fill this out, they have to respond to all of the yellow highlighted. There has to be something inputted in those areas. And one of the things that we have within this system is that when you go to order a unit of blood, the most recent hemoglobin concentration for that patient comes up. As you see here, right here, is this patient had a hemoglobin of 7.7. In addition, we require our providers to provide a reason over here for why they are transfusing a patient. And we have a couple of things that this does for us. It's called an adaptive alert, is that when a patient doesn't comply with the fact that perhaps their hemoglobin is 7.7, but the provider notates that there's acute bleeding with blood pressure instability, it basically bypasses all of our obstacles that we put into place for the clinician. And then we also have another category, mostly because we were interested in studying why people were going outside of what our evidence-based guidelines, and we're working on publishing a paper on what reasons people give for transfusing patients outside of our guidelines. And it's really interesting. Plasma is the most fascinating one, I think, to see what rationales people are giving. Speeding wound healing is one of the largest groups. At any rate, if basically the indication associated with the hemoglobin doesn't comply with our evidence-based triggers, then the provider will get a pop-up or an alert that looks like this, which basically states that you're not following our evidence-based transfusion guidelines, and perhaps you might want to cancel the order. And the default for this system is down here. It's pre-checked to cancel the order. Now, a high frequency of these orders they move the checkbox to the proceed with blood transfusion. And so what we're planning to do is to put a hard stop into place where, and I know the transfusion medicine docs here might reel by this, but what we're planning on doing is having them call our transfusion medicine physician anytime they are violating our evidence-based guidelines, so they can explain why they're doing it. So it's not a hard stop in the true sense that we've done with antibiotics, but it, I think, will highly discourage non-evidence-based transfusion. So the success for some of these alerts is demonstrated here. We had, with our FFP or plasma alert, we had about a 25% reduction in aberrant plasma orders. This is the effectiveness of our RBC alert, where we dropped, or what is being shown here is the numbers of orders that were outside of our evidence-based guidelines for a particular 6-month period. And you can see in one hospital we had 2,000 of them, which, I mean, is kind of a staggering number. And the provider only listened to us 12% of the time. Yet, with the volumes of blood products that we use, it's still translated a fairly sizable dollar figure. But we're, again, moving forward and trying to reorchestrate these particular systems to try to make this more effective. And part of that is an educational campaign that we're running across our health system to try to get people to use blood products more effectively. One of the things about these alerts is we can drill down into which specialties are ordering them outside of our guidelines. What we find, at least with this one, I don't think this has the specialties per se. This is the services. You can see that general medicine, I think orthopedic surgery are some of the outliers that we see. And then we can drill down to individual providers, which is, kind of the same kind of system that Haemonetics will sell you with the Impact Online system, except that we've refined this to some extent in that we know who is transfusing outside of the indication, so it helps us focus. Whereas the Impact Online system tends to look at all blood product use, so you have to go in and dig into the material that they provide in order to get some idea of where the aberrancy is coming from. So the second point in our PBM strategy is to eliminate waste, and these are things that I think that the blood banking industry has focused on for quite some time. Though I think that the value of having a patient blood management program is then what you do is you align transfusion medicine with clinical champions to try to better address waste. And there's a lot of waste, at least in my system. It starts with preoperative autologous donation. Back in 2005, we were wasting around $340,000 of preoperative autologous donation where it was just not being used. This is what's happened to that number, where we're down under $100,000 and still have some opportunity to go. Other places is trying to eliminate waste as it relates to blood products being returned to the blood bank with various things that lead to them being wasted. And so we're doing some lean management to try to understand where that waste is occurring. But we have another $300,000 of blood products that are just thrown out because it's either a platelet unit that's been put on ice as it's being returned to the blood bank, or it's outdated. And from my perspective, this is a lot of blood. I mean, this is a chart for 6 months of data for a number of our hospitals where we threw out 310 units of red cells, and that's how many 310 units of red cells is. And I think this basically presents itself as a huge public relations disaster for the transfusion medicine community, because you have all these people that basically contribute their time, their energy, and their blood. And if they knew that they potentially could have that blood wasted, I think it would be bad. So we've, again, tried to reduce this waste by applying some lean methodologies, and we have a goal of a 75% reduction. Other places I think that where waste can be reduced is better understanding the circumstances where we have high CT ratios. And it's interesting, what's happened in our system is we've started using less blood. So our MSBOS basically is based on historical blood use. And for instance, in cardiac surgery, blood use has fallen precipitously, so that we have this recommendation from the MSBOS that requires our surgeons to cross-match more patients than they actually need to. So for our cardiac surgery environment, our CT ratios are quite high without us having altered our MSBOS. So we're building our MSBOS into something that will be electronic and be basically timely based on DRG or CPT codes for individual surgical procedures. That's real time, so that we can basically give real-time recommendations. Yes?
Do you do electronic cross-match?
Yes. Yes.
But you don't cross-match on demand?
I probably have to talk to my blood banking faculty about that question. But this is one of the areas that we are focusing on. And in addition, we've seen very high cross-match use in OB. And what's happened over the last decade is there's been an increase in maternal mortality in the United States to the point where in California for non-whites, the mortality rates run around 55 out of 100,000 deliveries, which comes to almost third world numbers. And some of this mortality relates to hemorrhage. And so there's been a number of organizations that have tried to address increasing OB hemorrhage, and one of them is the California Maternal Quality Care Collaborative that has one of the recommendations is that you recognize patients that are at high risk as they enter your labor unit, so that you can basically do what is recommended here on the top, is that here for low risk patients you provide a clot only. Here for medium patients is type and screen, and those that fall into a high risk category you type and cross match. So our cross match to transfusion ratio in this particular environment is about 10. Which is way off the benchmark, which is 2. And it's all being driven by this particular recommendation from the California Maternal Quality Care Collaborative. And there's a lot of hospitals across the United States that are adopting the strategies that have been implemented here. Well, we found in our environment, my hospital, we're up to about 12,000 deliveries for the coming year, at least that's what it's projected. But for 2011, we did 10,134 patients where we used this risk stratification. And we found that here in parentheses and in bold, if I can get it, the arrow, is the percentage of patients that fell into each of these groups that actually bled enough to be transfused. And so we do see an incremental increase in going from a low-risk group to a high-risk group, where we have 0.8% of the patients in the low-risk group, whereas it's 7.3% of the high-risk group that get transfused. But it's still, at least reading information about the MSBOS, this still falls way under where we should be in terms of typing and cross-matching somebody. This should be in a type and screen category, barely. In terms of what we should be doing. So this is an area of discussion with our obstetricians to try to get them to come back in line with what they truly need. And it's very difficult to discuss it with them because there's so much emotion involved in talking about young bleeding women. So moving on, the third point of our strategy is preoperative anemia optimization. This was one of the Joint Commission performance measures that we developed, and this particular performance measure was actually one of them that had been voted to be cut from our project, except that there was a couple very vocal individuals on the committee that felt this is probably the most important of the performance measures that we had created. And I think I was one of those fairly vocal people, because it's a problem that takes on a large scope. Give you some sense of how large here over the next 2 slides. This is some data from the Cleveland Clinic when I was there, where we looked at patients that were transfused during the course of their surgical procedures. And here on the x-axis is their preoperative hemoglobin level. And so what we found was that the average hemoglobin concentration for patients that subsequently were transfused in the operating room was 12.2, which for men is anemic, and for women it's almost anemic. So in other words, 50% of our patients were entering the operating room for major blood loss surgical procedures where they were anemic going in. So the scope of the problem is sizable. We also did some audits within our own health system at UPMC, where we found, we audited 188 patients here and found that 28% of our patient population was anemic based on these WHO guidelines. and that anemic population was 4 times more likely to be transfused than patients that were not anemic. And this is just a random audit. My initial way of going about solving this particular problem is I thought I'd be really clever and go into all the surgeons' offices and give them hemocus, which is shown here, which takes, I believe, 10 microliters of blood to give you hemoglobin concentration. And more recently, there's this device, which is a device manufactured by Massimo that shines 7 infrared lights through your finger and actually comes up with a hemoglobin value. That there's some controversy about a certain amount of bias between this device and a Coulter counter, though I think we're measuring different things with this particular device. It's shining a light through a finger, so you're looking at the hemoglobin concentration of all of the blood pools in the finger, whereas when we're using a Coulter counter, we basically stuck somebody in a vein, and so we've got a centralized blood sample. And so the device really measures different things, but it can be used as kind of to guide your therapy and to identify patients that are potentially at risk of being anemic. However, when we introduced these devices to our surgeons' offices, we did a pilot, and there was a lot of pushback from the office nurses because they felt that the first thing they did after scheduling the patient for a surgical procedure is they would send the patient to the lab for a blood draw. And so they didn't see why they needed to have this second blood draw or second sample. And what we've done is we've tried to streamline our information systems. But before I get there, one of the things about the Joint Commission performance measures is it has this requirement for screening anemia 14 to 45 days before the surgical procedure for specific indications, which is basically orthopedic and hysterectomies, or orthopedic total joint procedures and hysterectomies. And this particular management measure has been picked up by our local Blue Cross Blue Shield provider as a pay-for-performance measure for us, and that's why I highlight this 14 to 45 days, because it's important for multi-million dollars worth of performance incentives. And so we've looked at our overall patient population, how soon they present before they get to our operating rooms in terms of pre-op hemoglobin testing, and you can see that the largest majority of our patients present in time to comply with this particular measure. Now, what we've done, to address the nursing concerns about doing double testing is that we've tried to leverage our IT systems, and this is a schematic that was put together by one of our IT guys, and I don't have much understanding of what many of these boxes mean, but the primary boxes are this box right here, which is our SurgiNet surgical scheduling software, and this is our laboratory information software. And so what we do is we link these two schedules so that we have a program that looks forward 8 weeks to see if a patient has been scheduled for a surgical procedure, and then it looks backward 8 weeks to see if they have laboratory data. And then what it does is it applies those World Health Organization criteria, and it sends an alert to the surgeon and the PCP that sent the patient to the surgeon. And this is one of the things that we found difficult with creating preoperative anemia clinics, is that the PCPs get really bent out of shape that you are managing the medical needs of their patients. And it's perceived to be a threat to their practice when you're taking patients away from them and sending them or routing them into a pre-op anemia clinic. So what we do is we send an alert, and this is old language that we used. It's a little too wordy here, but it sends an alert to the surgeon's office, and it also sends one to the PCP telling them that their patient is anemic, they're having a surgical procedure, and fix it. Unfortunately, as we pilot this particular program, a recent case was that we sent this alert to the PCP, and what did he do? He turned around and sent the patient to the ER of his local hospital, who then transfused him. So that's why we pilot these things, is to try to figure out. So clearly we have some issues with education, and unfortunately the numbers of physicians that we have referring into our hospital is huge. So it's a somewhat daunting task. Next step on our strategy is point-of-care testing. And this is a cart that I had in the operating room at the Cleveland Clinic, where I had a device called the Sonoclot, as is shown here, which gave us kind of the same information that a TEG did or does, except this device is portable. We also had a HemoQ and then a CoaguCheck, which gave us PT-PTT monitoring. We could move this basically laboratory on wheels, low, from operating room to operating room based on where the blood loss was occurring. Now, when I arrived at the University of Pittsburgh, they wouldn't support the Sonoclot from a laboratory perspective because we already owned 44 TEGs, and so they didn't want to do any more validation on a new device. So we were kind of caught between a rock and a hard place, and so we ultimately went with the TEG as shown here. And this particular TEG sits in the middle of our operating room, and a separate TEG sits in the middle of our labor suite. So we use this for making decisions about blood product transfusion in massively bleeding patients. There's some other point-of-care devices that are pretty nifty and worth considering. This is a blood gas machine that will hang from an IV pole. We use these in our cardiac surgery operating rooms as well as our transplant. This is the iStat that can do a wide range of things. So how does that translate into better patient outcomes? There's been 10 papers that I'm aware of in the cardiac surgery world that's looked at a TEG-driven algorithm for transfusion management. And this is one of them that Greg Nuttall published. Greg is at the Mayo Clinic, where he demonstrated these kinds of outcomes for cardiac surgery patients, where you have basically control where there was no TEG and no algorithm versus an algorithm-driven approach. And what he found is that there was a sizable drop in chest tube drainage in patients that were managed with the TEG and the algorithm. And he also found that the reoperation rate was significantly less in this patient population also. And one of the drivers for a surgeon is one of the big metrics for their quality measurement is reoperations. They get dinged for having a high reoperation rate. So if you can demonstrate to a surgeon that you can reduce that rate, then they will be receptive. Other investigators, Linda Shore-Lesserson in New York, has developed a very similar protocol where she demonstrated less plasma use in their cardiac surgery, or less mLs of plasma, less total exposures to plasma, as well as less exposures to platelets, using something very similar. Trauma surgeon at Denver Health Medical Center, who's no longer there, I think he's in Michigan now, Jeff Kashuk. He's a bit of a pariah within the trauma world because he doesn't espouse to the 1-to-1-to-1 transfusion ratios, but thinks that a rapid TEG, which gives you clotting information in 2 to 3 minutes, is a better way of approaching a patient. And I think this is starting to catch on, at least that's my sense. And what he showed is sizable differences between a pre-TEG and a post-TEG in blood use, and he also showed outcome improvement when patients were guided with TEG in this trauma environment. So we've also, moving on, education, physician awareness, and some auditing. Our bloodless program falls under this particular step where we do some education and create increasing physician awareness that perhaps we should be paying a little more respect to our Jehovah's Witness patients. But within this program, we try to figure out where our blood is going. One of the places that we discovered when we first started doing some of this auditing was that ECMO consumed, or at least ECMO-related diagnoses consumed huge amounts, and this is adult ECMO. We only have about 80 patients a year that get placed on adult ECMO, and those 80 patients consume 28,000 units of blood products, which is substantial. So what we've tried to do is, I have assigned one of our junior faculty in the anesthesia department to start figuring out what they're doing with ECMO, and what we currently have, our practice is that we don't want to clot up the pump, so we continuously heparinize patients even though they're bleeding. And so then we pump blood products in, hoping that the heparinized patient will stop bleeding, which is somewhat nonsensical. So we're trying to learn from the Mayo Clinic, where they have initiated an algorithm approach to dropping heparin concentrations as the patients bleed. And hopefully we can remedy some of that blood use. We've also changed the circuits that we use for our ECMO. We use a circuit now that doesn't require any blood priming, and started implementing point-of-care testing in this particular environment. Another source of audit that we're generating is we're generating reports such as this for high blood loss surgical procedures that are being done by large numbers of surgeons. And what you see here is the surgical practice for 50 surgeons that do total hip replacements in our health system. Each one of these bubbles represents a surgeon, with the size of the bubble reflective of the number of surgical procedures or total hip replacements that they did in the reporting period. On the x-axis here, what we have is the percentage of patients in that surgeon's practice who were transfused, with the y-axis being the numbers of units that those patients were exposed to during each transfusion event. So you can see huge amounts of variability in transfusion practice, and I don't think this is all related to transfusion per se, but there's lots of different ways that surgeons do these operations. There's lots of different DVT prophylaxis regimens, and then each of these surgeons uses different transfusion triggers to transfuse patients. So there's a lot going on. And we're in the process of developing some care pathways to try to bring this variability into a more standardized practice. But there's huge, yeah.
Did you look at blood loss per surgeon?
Well, I can tell you this guy.
Yeah, they probably can't hear it. Can you repeat the question?
Oh, the question is did we look at blood loss in for each surgeon? One of the things about blood loss is it's notoriously inaccurate. However, this guy's OR, okay, right here, his OR apparently looked like somebody had come through with a chainsaw and splattered blood everywhere when he got done. So there's clearly a relationship between the amount of blood loss that's lost. The other thing that this guy does is he uses a minimally invasive one-hole approach to replace a hip. And so what he does is he makes a 1-inch incision at the anterior portion of the hip, and he replaces the joint, and post-op the patient has bruising that extends basically from the nipple line all the way down to the ankles. And their limb is typically huge, and so it's easy to understand, where the blood is going. It's all into that joint. Some of our other surgeons, they Coumadinize patients before they start the surgical procedure. So as you might guess, they might use a little bit more blood than some of the low end. And this is an early report. This particular surgeon is now at 0% transfusion rates, as well as some of his partners. We have 5 surgeons at my hospital that have a 1% transfusion rate for all of their total joints, including their redo hips and knees, which tend to be fairly bloody procedures. And one of the things that we've noticed is that we've boiled down to the impact of this variability in practice. And we see a fair amount of association between length of stay and whether the patients are transfused, though again, I think this relates to this huge variability in surgical practice. It's not all related to blood, but you can see that the patients that do get transfused, at least in third quarter 2010, they had about a half a day length of stay less, and the cost for their care, at least in the third quarter, was $11,000 less, which is sizable when you do 5,000 of these things over an annual basis. We also saw a huge variability between surgeons. Here's a surgeon, $54,000 for taking care of a total hip, whereas this surgeon double that. So as we talk about healthcare reform, I think it really is very important to follow the world of the laboratory, where you tend to be much more rigid, I want to say anal, than the rest of us. We tend to be cowboys in the operating room, but I think we can learn a lot from standardizing our processes. But what we've seen here is, when we first started this project, we were using about 2.3 units per total hip replacement, and now we're down to about 1.7 units per case. And I think that number is going to drop again. We have rolled out the use of tranexamic acid in these procedures, and that's what's driven some of our surgeons to have 0% transfusion rates in their total joints. So lastly, I just want to talk briefly about autotransfusion, which is what got me into the blood management world. I started my interest providing care for the biggest blood loss procedures that the Cleveland Clinic performed, and I quickly discovered that when I was good at using autotransfusion, the patient outcome was dramatically different than when I went to the blood bank. And so I started looking at ways that I could optimize the use of these systems, and there's a whole litany of things that you can do to get more blood out of the surgical environment. But I think nationally, the utilization of this particular system or therapy is hampered by a total lack of training. Most salvage units are operated by circulating nurses in the operating room, and circulating nurses, when the blood loss is occurring most vigorously, they're responding to the needs of the surgeon on the surgical site. And so oftentimes what happens is the nurses will pass by the machine, push the automated button, and go about their business, providing the various supplies needed for the surgeon. And they'll not really pay attention to what's happening with this device. And there's quite a few things, most prominently air embolus, that can kill a patient with these systems. So what we've done is we've developed a simulation program to try to train our technicians. And we have 172 technicians that provide this service in our health system. And what's being done here is this particular technician, who actually is one of my best, is being fooled into creating a scenario that would lead to a major air embolism. And how that happens is the anesthesiologist here is putting a pressure bag onto the primary reinfusion system from the cell salvage machine, and then he's spiking his IV into it. So whatever air is in this bag right here is going to be pressurized right into the patient. The New York Board of Health has done some data collection. This happens about 1 out of 30,000 cases of cell salvage. So it's critical that you don't allow a pressure bag or an IV to be directly spiked into that primary reinfusion system. In addition, I don't think that most of these devices are operated with any level of standardization. And I've become a huge advocate for the AABB's perioperative standards, which put a quality system into place for the implementation of blood salvage. And these are 2 of the documents as it has evolved. I believe they're on a 5th edition now. We have all of our hospitals accredited by the AABB. And it's a source of great pride for me because there's only like 27 hospitals in the United States, and we got 20 of them that are accredited according to these standards. So another factor that leads hospitals away from blood salvage is a perception that it's very costly. And this is a study that we published in Transfusion last year where we looked at 19,000 cases that were performed over a 5-year period in our system. And what we looked at is the value provided by the blood that we basically processed and what it would take to replace that with allogeneic blood. And it would have cost us about $6.5 million. And the cost for providing that service was about 4.3. So from a cost perspective, it seemed to save us money. Now, you could always argue that the units that we were producing off of these systems weren't necessarily needed, though we don't implement our full system unless the patient's hemoglobin is dropped below 10. But what we found, and if you equate a unit of salvaged blood, and what we do is we weigh every unit and we measure hemoglobin on every unit, so we know exactly how much red cell mass is in every unit that we provide for our patients. So we can equate that with a unit of blood from the blood bank. And in general, the definition of the red cell volume is around 200 cc's of red cells in a unit of blood coming from the blood bank. And so we are able, based on how we measure the weight and the hematocrit, we're able to convert that into the same kind of metric as 200 cc's. So what you see here is the number of units that we provided based on this definition. Packed red cell equivalents is what I call it, where we have a large number of cases, 16.8% of our cases is shown here, where we didn't collect enough to actually process. We had a larger chunk of patients here where 30% of the cases only produced 1 unit, and then we had this kind of skewed decline. Though overall, we produced 2.3 units of red cell equivalents per case. So it makes it a fairly cost-effective program if assuming that you're replacing 1 unit for 1 unit. So these units are costing us about $75 compared to $181 for us buying a unit of blood from ITXM. So that's our strategy. And what we've seen is a fairly sizable reduction in our blood product use. Last year we saw a 9% reduction in blood product use in the first half of this year. And our fiscal year runs from July 1 through June 30th. So this is fiscal year 2013 here, where we had about a 20,000 unit reduction in blood product use, which translates for half a year into $1.8 million. So if we're on track to the same extent, we should save close to $4 million this year, which I'll tell you is a lot of jobs. And as we move towards healthcare reform, there's going to be a lot of jobs at stake, I think. So the more we can do to protect ourselves, the better off we'll be. So I will stop there, and this is a picture of the center of the campus of the University of Pittsburgh 2 years ago after a 30-inch snowstorm, which shut the city down because they treat snow like it was Houston. So anyway, I will stop there and answer any questions that you might have.